Hey guys, Woodruff here. A much requested topic that has been asked for has been electrolyte imbalances. So I went ahead and made a video. Hopefully this has what you're looking for when it comes to electrolyte imbalances. I'm going to try to break down the common imbalances into what causes them, what are the signs and symptoms, and then also how do we treat it or what do we do? And there'll be some other, tidbits and tips and stuff like that as we go along. So hopefully this is helpful to you. So, what are electrolytes? Why are we studying these? Why is it so important? Electrolytes control and manage a lot of important functions, including the body's fluid balance and just general fluid levels, like where fluid goes in the body. They're also in charge of nerve impulses or how your nerves talk to different areas of your body, including your muscles, your diaphragm, things like that, too, including your electrical impulses in your brain. They're also responsible for muscle contractions if your electrolytes are off. Think about, if you're one of those people that enjoys or likes exercise and you're a runner and you don't keep up with your electrolytes, you can get those muscle cramps and other issues as a result. They also involve the most important muscle in your body, your heart. And when I say most important, that's my opinion. All muscles serve a purpose for sure, because I guess you could argue that the diaphragm is more important because you wouldn't breathe. But if your heart's not beating, it's kind of it's good argument. But anyway, point is that your heart rhythm is also affected by how your electrolytes are, or if your electrolytes are imbalanced, you can have arrhythmias or dysrhythmias. Bicarbonate is an electrolyte and also affects things like your pH balance. And then there's electrolytes that involve like energy production or your ability to have and expend energy. So let's start with potassium. And potassium is probably one of the most well-known electrolytes, and it's one of also the most deadly when it's off. I put these in order with the imbalances that you're going to see most often, and also, at least in my experience, the ones that in the hospital, you're more likely to need to do something right now versus as we go on, the ones that I wouldn't say they're less important, but just have less life or death kind of consequences more commonly. Um, Hyperkalemia or high potassium. I will preface that all textbooks, things like that, your professors may have different laboratory values. So the ones that I have on these slides, please go by what your professors or your textbook tell you. Do not necessarily use these ranges if they do not agree with what you're doing, because every professor is going to use what their textbook is. I went with what is the most common standard or overall seen as quote unquote normal for most people, but there is a wide range for some of these electrolytes. So, what causes high potassium? The most common issue is going to be kidney failure or kidney problems. Like people that are in complete kidney failure that need dialysis or on dialysis are going to have a high potassium. That's actually one of our cues that, hey, it's time for this person to need dialysis. Like, let's say it's someone who has chronic kidney or comes in with a kidney crisis. If we're trying to decide do they need dialysis or not, one of the things we look at is are they managing their electrolytes, particularly their potassium? Because yes, there's meds and things we can do to treat it, but if their kidneys aren't excreting it right, then this patient, it may be time that they need dialysis. So kidney problems is a very common one. Medications can increase your potassium. That's stuff like ACE inhibitors and ARBs, are one of the big ones that you might see. So you want to look at your medication profile or talk to pharmacy and see if there's anything that could be increasing it. There's also meds that we stop when potassium's high because we're trying to, keep an eye and make sure that it's not going to be getting worse. Another big one is you want to think about your patient's reason for being in the hospital. If they're there for any sort of trauma, crush injury, burn, all of these things break down muscle tissues. And where does a lot of your potassium is stored in your muscle cells? And so in the intracellular space. And so if you break down a lot of muscle tissue, a lot of muscle in general, or you have a lot of breakdown of tissue and crush, things like that, you're going to have an increase overall in potassium because of the breakdown of that tissue or muscle. And the big thing to keep in mind here is that when you have an influx of this all rushes to your kidneys and can actually lead you into going into kidney failure, which can make your potassium even worse. And so, yeah, it's something we really keep an eye on. Usually, that's why a lot of these patients get a lot of fluids when they come in for this type of patient because we're trying to effectively flush out all that extra potassium that's being lost that way. People that are in a state of acidosis are going to be more likely to have higher potassium levels. That's just because in a state of acidosis, the way that the body works is that it moves potassium out of the cell into the bloodstream with acidosis. And so you're going to want to keep an eye for your patients that maybe have a metabolic or respiratory acidosis. Other things to consider is something simple, excess intake. And now it would take a lot of intake. Usually, excess intake is also paired with someone who has kidney problems. But it is possible if someone is just chomping down those foods, those high potassium foods, that it could also be something that could be a problem there. So what are the signs and symptoms? I think, in my experience studying and learning electrolytes, the hardest thing is that a lot of the symptoms are the same. So I've tried to come up, some of these slides are going to have some mnemonics on them, so hopefully those are helpful to you. But for hyperkalemia, think hyper, tall, wide, and weak. And what do I mean by that? The other, real quick too, I'll say the other thing I think that helps to break these down is look at, okay, for this electrolyte imbalance, which parts of the body. So even if you don't remember exactly what's wrong with it, if you can remember what parts of the body are more often affected. And for hyper and hypokalemia, it's all about heart, muscle, and GI. I think there's also some respiratory involved for hypo, which we'll get to next. But heart, you could think heart, lungs, muscle, GI. So for the heart for hyperkalemia, things are going to be tall. So peaked T waves, that means they're very tall. You're going to have a wide QRS. They have a high chance of going into cardiac arrest. This is why, when, we say you never push IV potassium and that, the lethal injection, sometimes what is used is an injection of potassium. And that's because at very high doses or given rapidly, it can cause your heart to stop. On the opposite end of the spectrum, there's these really high T waves and wide QRS. The muscles themselves can be weak or numb. And then for the GI system, it's hyperactivity or like diarrhea is what you're going to see. So hopefully that hyper, tall, wide, and weak will help to remember um, the hyperactivity in the bowel, the tall T waves, wide QRS, and weak muscles. So what do we do to treat hyperkalemia? We get rid of potassium. So one of the things, and you're going to see this for a couple of electrolytes, is we give calcium as a protective mechanism. Calcium effectively helps to stabilize the heart. So if there's a lot of shifts of electrolytes, it can really throw off the heart and it gets very unstable, more likely to have those arrhythmias or dysrhythmias. And so one of the things we want to do is kind of like since we're going to shift some potassium back into the cell with our treatment, that shift can cause some instability in the heart. So one of the first treatments you want to give is calcium gluconate as ordered, of course. But it's something you would want to suggest, hey, does this patient need calcium before we start treating this? Now, if they're just a little mildly like a 5.1, 5.2, they might not need it. But if we're going to do any of these other more intense treatments, especially if it's like we're at emergency levels, like their potassium is 6, then we usually start out with a calcium. Then it depends on how high is it. If their potassium is not that high, like I said, just like a little bit high, maybe 5.2, 5.3, we might start with something more, and they're not like showing any signs of like instability. We start with something. Now, you probably won't have this in your textbooks because it's something newer that we're doing, but we might try with something a little bit more gentle, like a low kalima, which is something that it's like a potassium binder. It goes through the GI tract. We also do things like albuterol, sodium bicarbonate, diuretics. We can do oral or rectal options with like Kxalate and things like that. That helps to bind potassium that's in the GI system and help to excrete it. And of course, we're going to avoid anything that increases our potassium. So that's if things are stable. But if they're unstable, what you're going to see for more emergency treatment is one of two things. If it's really bad, or they're a renal patient, like on dialysis already, they need dialysis. This is their sign. There's tons of patients. I'm located in Texas, and we have a lot of people that we give what is called compassionate dialysis. They can't afford or don't have insurance to get their dialysis. So what they have to do is wait until it gets bad enough that they come into the emergency room. Then we have to emergently, dialyze them. And so, but for those patients that it's very serious and they don't necessarily need dialysis yet, which by the way, dialysis in general, you're going to see as a treatment for a lot of times for electrolytes when it's too high. If it's emergency toxic levels, the only way sometimes we're going to get that off is by pulling it out with dialysis. But anyway, so aside from that, then what we have is, and we call it redneck dialysis out here in Texas, but what it is, it's a combination of insulin and dextrose. Usually it's that calcium first, and then insulin and dextrose. And what that does is insulin pushes potassium back into the cell. Now, a lot of patients that are getting this treatment aren't diabetics. So that's where the dextrose comes in handy. So like we're giving them insulin IV, not sub-Q. We're giving IV insulin, and then we usually follow it up with some dextrose so we don't lower their blood sugar too much. And then again, we gave that calcium before to help stabilize their heart. That's usually the go-to treatment or the most common thing you're going to see is the insulin, calcium, insulin, and dextrose. And how much dextrose we give depends. Sometimes, like my hospital has a new policy that it depends on what we check a blood sugar. And if their blood sugar is below something, then we give them dextrose with the insulin. If not, then we don't give them dextrose because we also don't want to just give a whole bunch of sugar to someone who already has a lot of sugar in their veins. So anyway, but yeah, so that is hyperkalemia. Obviously, you also want to have this patient on a cardiac monitor and be watching their heart rhythm closely throughout treatment. So how about when things get low? So hypokalemia. Causes on the other side for this is a lot about loss of things. So like diuretics cause you to lose potassium or you pee potassium with diuretics. And then also too much GI loss. So think if a patient has an NG tube and you're suctioning out a whole lot of things, or on the other end, if they have a whole lot of diarrhea or they're pooping a lot. If if I have a patient who has a low potassium, I can keep replacing it all day long. But if they're vomiting and pooping a whole lot until I get to the bottom of that, it's never going to get better. Also, too much insulin. So, if you've ever taken care of a patient or seen a patient who's in a diabetic crisis and their potassium's really high when they come in, then we give them an insulin drip, and then all of a sudden we're really struggling. This is because insulin pushes potassium into the cells, which is great when they're high, but again, it can lead to overcorrecting, and there can be too much potassium in the cell, and therefore not enough potassium available, and it gets low. And then, of course, if in acidosis, what's happening is that there's more potassium in the blood than in alkalosis, there's going to be less potassium in the blood. So on the opposite, where everything was kind of hyper high and wide, everything for hypokalemia is going to be weak and depressed. So again, the heart is affected, but this time, instead of having those wide QRSs or those peaked T waves, we have ST depression. They can have ectopy or PVCs, like where they're having abnormal extra heartbeats, where their heart's beating earlier, faster than it, not faster, but beating earlier than it needs to. And then what are called U waves, which is a wave after, what do you call it, after the T wave. Around the T wave that is abnormal. But a lot of times, what you're going to see most often is that ST depression. Muscles are weak and or cramping. So remember for hyperkalemia, they were weak and numb. For this one, weak and cramping. Again, hopefully your teachers aren't too tricky. The muscle weakness is really common in almost every single type of electrolyte imbalance. So it's not really good on its own to differentiate, what the issue is. Constipation. So remember in the other one, we had hyperactivity in our GI. So in hypokalemia, we have, a low motility or constipation going on. Then for this one, we can add in shallow, weak respiration. So as a whole, everything is weak and depressed with hypokalemia. So the treatment when something's low is we need to replace it. So, we can increase the PO in the diet, and yeah, that's great. There's things like, there's some things in this picture and stuff like that, like some meats, bananas, things like that, nuts, are all great for potassium. However, that's going to be very slow. So usually we give IV or PO potassium. And something that you wouldn't know if you've never worked in a hospital is I used to always think that, man, if someone's potassium is low, then I want to give the IV stuff because it's going to do so much better. But actually, PO potassium is better absorbed than IV is. So oftentimes you need both. So if you're ever wondering, man, why did they like my potassium is not that low? Why did they order PO and IV? Is a lot of times they need both in order to ensure that what do you call it? That there's better absorption. It's all about the absorption. So, things to keep in mind, PO potassium are big pills and they usually sometimes cannot be crushed and things like that. So, kind of keep in mind when you're administering the potassium, you're kind of reading all of your instructions and things like that. And they are big pills. So, some patients just can't swallow them. They have powders and stuff too, but if it's anything like my hospital, they're more expensive. So often they do not like, unless someone has like a feeding tube, they don't like to use those if possible. But it can be challenging for some patients to take the PO replacements. It's also hard on the stomach, so make sure that they're eating or getting something with that. Otherwise, it can upset their stomach. And if you are giving it through a feeding tube, it can clog a little bit. So make sure you add enough water and mix enough stuff with it. And then we often give IV potassium replacement. This burns in the vein. So usually you want to give it with a little, like, even if it's just 20 mils an hour of fluid, listen to your patient. Make sure you put it in a good IV and that the IV is working well. And then when you're giving that potassium, again, just listen to your patient. You might need to slow the rate down a little bit and or again, like some gentle fluids with it. Um, and then, of course, you want to treat the underlying cause. Like I brought up, if there's some sort of medication that they're like losing their potassium too much too fast, we might need to stop that medication. And the biggest thing you can do is stop the GI losses. If they're vomiting or have a ton of, suction output, we might need to talk to the docs about an antiemetic or what's going on that they're losing so much GI fluid, from their upper, or if they're having a lot of diarrhea, are we still giving them their bowel regimen even though they're having a ton of diarrhea or pooping a ton? Because it doesn't even have to be diarrhea for them to lose potassium. I say in other videos, you poop potassium and it's no joke. So yes. All right. So let's move on to sodium. So sodium is our water pooler. So in other words, wherever sodium is, water goes. So a lot of this is going to have to do with fluid balance, and a lot of this is going to have to do with your beautiful brain. Because yes, you can get edema and swelling in other areas, and it's no good. But when there's swelling in the brain, it gets very difficult. And when sodium is off, it messes with your brain fluid balance, which messes with your neurostatus. So high sodium. Think anything for causes, think anything that causes you to be dry. So any cause of dehydration, diabetes insipidus, where you're peeing a ton, anything that causes you to be dry, like a fever or heat stroke, or osmotic diuretics, that would be things like mannitol, can cause you to have the high sodium content because you're also going to be like again getting off a lot more fluid. And when you have less fluid, you have more salt. Um, Also, just excess sodium intake in general. So, in general, this patient's going to be thirsty, have a dry mouth, low urine output, all those signs of being dry. But the big things you want to look for is going to be a change in their neurostatus again, because this is where for hyper and hyponatremia, the guiding symptom, you see nothing with the heart, nothing with other body systems. It's all about the brain. So this is all about neuro are going to be your most common symptoms. So dry and neuro for this patient. Um, Confusion, irritability. When it gets really bad, they can have seizures. I've seen sodiums up in 190s, and they've been in rather lethargic or pretty rough states, pretty confused. So for sure, you want to watch their mental status and be keeping a close eye on that. So the way we treat this is, of course, we need to treat the underlying cause. If there's a medication that's causing it, then we need to treat that. If they're in DI, we need to treat that. If they're dehydrated, we need to treat that. And we usually treat it, keep in mind with sodium treatments for both of them, we always go slow because we do want their sodium to get back to normal, but we don't want it to happen fast because those fast shifts can be very dangerous. So, most of the time these patients are going to be on a low sodium diet or low sodium restriction. And then we do a slow correction with hypotonics. That'd be like 0.45 normal saline or half normal saline. We're going to obviously avoid anything that has too much salt in it. So then the more dangerous one are the ones that I'm going to see you're more often worried about. Oh, and real quick, going back, one other thing you're going to see is if you have a patient who is on tube feeding, there's a lot of salt in tube feeding that's like packaged like the formulas. And so what you want to always keep in mind is that with patients that are on this, they're always going to naturally have a higher sodium. So often what the doctor needs to do is add free water or how much water that we're flushing them with to help get their sodium down before it gets too high. All right, so low sodium. So this is one that, I see more often. Patients come to the ICU all the time for low sodium because it's very dangerous and can lead to them being in a coma. So this is the opposite of hypernatremia in that instead of there being dry issues, there is I am too wet, I am fluid overloaded issues. So there's too much fluid, not enough sodium. And there's not enough sodium, not because they're losing it, but there's not enough sodium because it's diluted. So this would be conditions like SIADH, which is the opposite of DI, which is a symptom of inappropriate antidiuretic hormone, which is where they're holding on to their antidiuretic hormone, which causes them to hold on to fluid. Heart failure and liver failure are both disease processes too that cause you to hold on to more fluid. So keeping that in mind, anything that fluid overloads you can lead to hyponatremia. Excessive fluids, whether, some patients have a psychiatric issue that causes them to drink too much fluids, or they just drink too much in general. Diuretics can also cause this as well. Just because of the way diuretics work, they can cause you to waste sodium. And then GI losses as well. So for this patient, they have some generals, the headache, nausea, vomiting, muscle cramps, but I'll tell you the hallmark thing is going to be confusion, seizures, and then which can also progress to a coma. So the story I always like to tell, and I'm sure I've told this in another video, is that the one patient I had one time at my hospital that was a crazy story for hyponatremia was this guy who got low sodium, and I don't remember why he had low sodium in the first place, but he was found at McDonald's. He took all of their sauces and was literally opening the sauce packets and rubbing them all over his body. And so it's almost like a funny thing where he was trying to get more salt in his body, intradermal. But yeah, so that's why they were like, patient was brought here because he was found at McDonald's rubbing barbecue sauce all over his body. So the confusion is real, I guess is what I'm trying to say. So it's no joke. But yeah, confusion, like lethargic to the point where they're not waking up. So any neuro change, that's why neuro changes a lot of times are your sign like, hey, is there something wrong up here? But there also can be something wrong with your electrolyte balance. So for this one, remember, fluid is the problem. So we're going to restrict fluid. Remember, in hypernatremia, sodium is the problem. We need fluid, but we need it slow. But for this one, fluid is the problem. So we're going to restrict fluids. We often give them salt tablets. We give them isotonic fluids gently if their sodium is not too low. And of course, treating the underlying cause, whatever is causing their sodium to be low, we have to fix that because we can keep replacing their sodium, but if they're losing it or if it's getting leached or getting diluted or whatever it is, we need to get to the bottom of that problem. Now, this can get really severe when it gets to a certain level, and every hospital is going to be different. But usually when we get in the 120s, this patient usually needs to come to ICU because they need to receive a very high dense sodium drip called hypertonic saline or 3% saline. This is a very dangerous drug, and if not, managed correctly, can lead to death. So it's managed usually in most hospitals only in the ICU. But yeah, we come in, we bring them to the ICU, give them some hypertonic saline. And some people are saying, wait, you said that fluid is the problem. But when we give hypertonic saline, it's at very low doses. Like if it's very a small amount, so pretty much you get a big bang for your buck. A little bit of fluid, whole lot of salt. And it's at a very low rate that we usually give this. So now let's go into calcium. So calcium can cause a lot of problems too. For causes, you want to look at the parathyroid manages calcium and phosphorus balance. And so, looks like I'm gonna drink. Um, so you want to worry about parathyroid and bone issues. The most common thing I see people come in for when it comes to hypercalcemia has to do with they have cancer, and they usually have bone cancer that has metastasized, like a multiple myeloma, something like that. But people can have parathyroid issues. So we need to check their thyroid, parathyroid function. Then we also need to be looking for a possible bone metastasis. Other possible causes, if someone's super mobile, I'm talking about they haven't moved in a long time, then this can also cause calcium to build up, and then thiazide diuretics or just too much calcium or vitamin D. So a little, little thing to help you remember the signs and symptoms: moans, groans, stones, and bones. So the most common things you're going to see are things like constipation, kidney stones, bone pain. Because again, the bone pain usually comes, it can be from the hypercalcemia, but it's usually more because of the underlying issue. Like they also have underlying metastasis and stuff like that as well. They can have decreased reflexes, like their deep tendon reflexes. They might have confusion or lethargy, things like that as well. We had a lady who had like since I work in trauma, she had a femur fracture, and then she, unbeknownst to her, she also had multiple myeloma or some sort of bone cancer. I'm not sure. I don't remember which one. I want to say it was multiple myeloma. And the way that we found out was because of her calcium being so high. But she started out confused and really lethargic. She was like really awake one day, and then one day she wasn't. We checked her calcium. It was like 13, really high. And again, the most common reason for this is going to be cancer, unfortunately, but there is other causes too. So we need to get rid of it. So what do we do? When there's too much of something, one way we can get rid of it is dilute it. So usually IV fluids is one of the first things we want to do. We also can help them pee it out by giving them loop diuretics. Obviously not the thiazide, since that's one of the causes, but the loop diuretics are good. And then we can decrease it by kind of binding to it or decreasing it through medicines like bisphosphonates, or calcitonin. And then, of course, we need to treat the underlying conditions. People sometimes hypercalcemia can be a result of some cancer treatments, like it's a cancer complication, and then sometimes the cancer itself is causing it. So sometimes until we treat that, we can't really change anything. So it's a little limiting, unfortunately. Then there's also hypocalcemia. So, what's going on with hypocalcemia? It's the opposite end of the spectrum, of course, where there's hypoparathyroidism or low parathyroid function. It can also be in kidney disease or someone who's like, in kidney failure. Pancreatitis can cause low calcium. And one that you really want to be aware of is massive blood transfusion. So anytime you're giving a blood transfusion, if a patient's getting more than a unit of blood or multiple units at one time or multiple products at one time, they're really high risk for being low on calcium. So you'll sound really smart and also save the patient's life if you consider what their calcium is. And sometimes we just give calcium without even needing to know if it's necessarily low with multiple blood transfusion, just knowing. Because what happens is one of the things they use to preserve blood is citrate, and it leaches the calcium out of your blood when we administer it. So it's very likely that a patient who's receiving multiple blood transfusions in a short period of time is going to need some calcium. And then, of course, also poor intake. So the one that you always want to remember for low calcium, because teachers love to do this one, is tetany. Really quick, I came up with this thing: NATS, numbness, arrhythmias, tetany, and spasm for hypocalcemia. If you're a mnemonics person, but the one that they always love to go to is they love to talk about tetany. So there's a positive Shavastic sign, and the positive Shavastics is when you like touch their cheek here, they have like a spasm in their eye, or it's a facial spasm. And then with Trousseau's, it's like when you put a blood pressure cuff on them, their fingers come together. So I always remember Trousseau's two fingers, Chava's is the cheek. So they get pressure on the cheek and then it causes a spasm in the face. So these are signs of just like hyperactivity in the muscle. So even though the calcium's low, it kind of causes like a spasm in the muscle that causes that very tense tetany sensation. Sensation is really something you see, but yes. Numbness, tingling, and then muscle cramps and spasms are very common too. And they can also have a prolonged QT. For hypercalcemia, they can have a shortened QT. That's usually not as concerning. A prolonged QT is very dangerous because this is what it does. This is that I call the QT the toilet. So when the heart is supposed to be resting, it's waiting for the next heartbeat. We don't like that time to be too long because it gives more time that if the heart's going to have some irritability or something going wrong with it, that there's going to be an abnormal beat that's going to set this person off into VTAC or some other abnormal rhythm. We do not like a prolonged QT. That's why there's a lot of medicines like Seroquel, Zyprexa, and like antipsychotics and things that we check a QT on because they all prolong it. The more of them that you're on, the more chance that you're going to go into a deadly rhythm. So we do not like a prolonged QT. So these patients will need cardiac monitoring. This is where calcium can get very dangerous when it's low, is that we're worried about the muscles, including the beautiful heart. And so we want to watch out, and we're going to be watching for muscle tension, that tetany. We're going to be looking for muscle cramps, spasms, the numbness, tingling, but also the poor heart. It has that prolonged QT. It's going to be really high risk for those arrhythmias. So we're going to replace what's missing. We're going to give them PO or IV calcium, and we may also need to consider replacing vitamin D, depending, of course, on what they're missing. But that can help them to have better absorption of their calcium. All right, so let's talk about magnesium now. So for hypermagnesemia, which is not something, the only time I ever really see this is in patients that are in kidney failure. It's usually my sign that, hey, their kidneys aren't working when your electrolytes get off. But most people don't struggle too much with high magnesium. If they do, they're taking too much for some reason, or their kidneys aren't working. To remember for signs and symptoms for these patients, it's going to be they're low and depressed. Their blood pressure goes low. Their heart rate gets low. They get depressed deep tendon reflexes. They have respiratory depression. So everything is low and depressed. And so there's too much of something. So what we're going to do is get rid of it. We need to decrease if we're getting in too much intake. Like, the this a lot of times might come into play for someone who's on a magnesium drip in like the labor and delivery world, which I'm not going to pretend for a second that I have any idea or clue. I've had one pregnant patient on a magnesium drip and it scared me to dickens. Like I was like, this is not for me. I don't do this. It's not the best thing, but we keep a close eye on their deep tendon reflexes. I will tell you that I do remember that. So decrease the intake. This is another one where we want to stabilize the heart and the neuromuscular status or the neuromuscular tissues by giving the calcium gluconate. We can also waste it through diuretics if the kidneys are working, if the problem is not kidney failure. But if they are in kidney failure, or if they're at toxic levels, then we need to do dialysis. So diuretics or dialysis, and then of course so pretty much the 3 Ds: decrease the intake, diuretics or dialysis are our best options here. And again, that calcium just to stabilize. Then how about low magnesium? So this is going to be something you're going to see more often. Remember that, if you're having a problem where your potassium is low for a while, you also want to check your magnesium because sometimes your magnesium is low. And your potassium, you're going to be constantly chasing it till you fix your magnesium first. So if you're having problems where you're just constantly replacing your potassium, you might want to ask to see what the patient's magnesium is or check a magnesium. So most often it's going to be loss of nutrition, like malnutrition, things like that. GI loss, like diarrhea or fluid loss from diuretics. And also can be with DKA as well. These patients can have a lower magnesium, and alcoholism can also cause this. You're going to see a lot of times either with insulin, with alcohol, being an alcoholic, and the changes that happen in the body with that, the malnutrition and stuff like that. But also it has to do with things like refeeding syndrome. I'm not going to get into the weeds with that because I'll confuse you, but a lot of times just think as a whole, you're losing too much magnesium and and you can lose it through lack of nutrition, pooping too much, or losing it from diuretics. So everything with hypomagnesium, oddly enough, is hyperactivity. Think like hyper things like tremors, seizure. And the one you might want to know, because especially if your teachers are tricky, like I would love this question, not because I didn't love to be tricky as a professor, but I loved cardiac. So, I'd like to sometimes incorporate some cardiac into wherever I could. There's a special rhythm. It's a type of VTAC called torsades, torsades, decides to point. I never say it. I always call it torsades. I never say its full name. I feel like I'm calling it like I'm its parent, calling it by its full name. But it's a dad joke there, by the way. The big point is that it's a rhythm. It almost looks like an accordion. So it has like the typical like V formation, but it kind of goes ooh, like, it goes up and down. I should have put a picture on this. And too bad I'm thinking about it now. That would have been a great picture. Oh, I'm so sad that I missed out on that. But I guess that there's always a learning lesson, maybe next time. So I might make a separate video just to show torsades because it's so beautiful. But anyway, I know I have it in my cardiac videos. I'm going to get back on point. My ADD is starting to drift. So yeah, it's the hyperactivity and the torsades. Like you can give all the treatments you normally would do for VTAC, but if you don't give them magnesium, it's not going to get better. So this is one where an electrolyte actually causes a specific heart rhythm. So if it's low, we need to replace it. So we give IV or PO magnesium. This patient may need to be under seizure precautions. So that's like patting the bed and things like that, or keeping an eye, make sure looking for that activity. And then, of course, treating the underlying cause. If they're malnourished, we need to nourish them. If the diuretics are causing it, we need to hold the diuretics. If they're losing it from diarrhea, we need to stop giving them bowel meds or look at antidiarrheals. Last, and I'll be honest, kind of least, is phosphorus. And I say this because not to say that phosphorus, like some of the things that I'm going to talk about here sound like phosphorus is really important, but the honest truth is people don't care that much about phosphorus. And it's definitely not one that you're going to call the doctor in the middle of the night for phosphorus, because even if it's high or if it's low, there's not a lot of emergency treatments that we're going to do unless the person's in like fulminant renal failure or something. And this is just one of other labs that are also very dangerous. But just if their phosphorus is the only thing that's high, we're not going to do emergent dialysis for a high phos. So anyway, let's get into it. So causes are kidneys, cancer, and parathyroid. So renal failure is going to be one of the most common causes for it. There's a cancer complication known as tumor lysis syndrome, and it's kind of where when sometimes the tumor, gets broken down, your electrolytes get off as a result of what is let go of from that, from the tumor lysing and things like that. The other thing to consider is the parathyroid, which, calcium and phosphorus work opposite, or they have an inverse relationship. So if my calcium's high, my phosphorus is low. If my calcium's low, then my phosphorus is high. So there you go. I was going to say it backwards, but yeah. All right. So you just want to kind of keep that in mind. So if you're watching someone's phos, you might also want to keep an eye on their calcium. And I'm not saying that every time a phosphorus is high, a calcium's low, but it has, they worked very inverse. So you want to always keep an eye on one if you're keeping an eye on the other. So for a high phos, it looks the same or similar to hypocalcemia. They can have things like tetany, maybe not to the same extent, but pretty close, because sometimes they might have high phosphorus and low calcium. But numbness, tingling, muscle cramps, and spasms. So very similar to that. And the treatment that we do for high phos is we bind phosphorus and we restrict it. So there are medicines called phosphate binders. This is what kidney patients, people on dialysis long-term use, is phosphorus binders or phosphate binders. We also want to restrict phosphate intake in patients that have this chronically. They're going to be on a low phosphorus diet. Obviously, like I said, if it's severe, paired with other severe electrolytes, then they need dialysis. But I'll tell you in general, I've seen some phosphoruses that, yeah, phosphi. I don't know what the plural of phosphorus. Phosphoruses, pretty high. And that we didn't do anything about it because we're just like, hey, they're going to get dialysis tomorrow. It's no big deal or whatever. So it usually doesn't cause too many issues, but it's something we might keep in mind. Main thing we do is the phosphorus binders and restricting phosphorus. All right, so then last and also maybe least is low phosphorus. Do not call the doctor in the middle of the night for a low phosphorus, even if it seems dangerously low. It's maybe if it's critical, sure, but you're gonna get, if that's the only lab you're calling about, you're probably gonna get like a, we could have dealt with this in rounds, or a hang up. So causes are gonna, this usually something, what I'm saying is not that this is not important, but it's something that doesn't need to be dealt with in an urgent manner. So, most of the time. So the causes are going to be malnutrition or that refeeding syndrome, like I was talking about, someone who's in alcohol withdrawal, and that just has to do with usually when they're in alcohol withdrawal, then they're starting to eat again, and then they have the whole refeeding syndrome, which leads to phosphorus, being wasted. Then antacids like Tums, so things like Tums are made from calcium and they bind phosphorus, and so they can leach that phosphorus out of the body and cause you to be into a state of low phosphorus. So signs and symptoms are going to be weak and failing. So muscle weakness and breakdown, respiratory failure, confusion, irritability. And again, I've never seen a patient and been like, "Oh my God, do they have a low phosphorus?" Like, so, yes, these things sound super scary, but very rare that this is going to happen. And what do? We replace it. So PO or IV phosphorus. We usually can do sodium phosphate or potassium phosphates, and we usually just look at which one is better, like what's their potassium, what's their sodium, and which one would be better. We want to treat the underlying cause, and then, of course, monitor their calcium because they work inverse. Anyway, that's it. I hope that this was helpful for you today and give you what you were looking for. And next time I'll do better with the cardiac pictures. I'm so sorry I let y'all down. It was great seeing y'all. See you next time.